We present a case here of RF ablation of a large nodular colloid goiter. This is a story of a 42-year-old female patient presenting a large single nodular colloid goiter occupying almost completely the left thyroid lobe, becoming symptomatic and progressively increasing in size, and causing a deviation towards the right side of the trachea for about 1.5 centimeters. This goiter underwent final aspiration biopsy with the result of a Thigh-2 lesion. These are the images of this large goiter with a large cystic component, even if most of the tissue is solid. On the right side, you see the image with contrast-enhanced sonography, demarcating very well the liquid from the solid portion of the nodule. In the pre-ablation phase, the size of this lesion was 6.5 by 5.7 by 4.0 centimeter for a total volume of 77.5 cc's. We performed initially a pre-medication with paracetamol, ketorolac, midazolam, and ondansetron with the dosage indicated here in the slides. Initially, we prepare the ultrasound probe with the insertion of the probe into the protection, the sterile protection, in order to facilitate all the procedure. And secondarily, we perform a pre-treatment ultrasound scan with the main purpose to confirm the location of the lesion and particularly to detect the geometrical center of the nodule, which is the point where we will perform the local anesthesia and also all the therapeutic procedure, because through this single hole, we will reach all the different portions of the nodule, performing the ablation for the entire lesion. Secondarily, we perform the local anesthesia, injecting a 2% lidocaine, exactly as I said, in the geometrical center of the tumor. This will be the only hole through which all the procedure will be performed. After that, after the anesthesia, we perform a small skin incision at the nodule center in order to facilitate the insertion of the electrode during the ablation. Initially, during the procedure, we tried to extract from the lesion almost all the liquid content. And we were able to aspirate 42 cc's of fluid, but we noticed a very quick reformation of the fluid, getting the procedure of aspiration completely useless. As regards to the radiofrequency ablation, we use the moving shot technique, which means that we localize the center of the lesion, and at that point, we perform some insertions using the same entrance point through the skin, but reaching all the portions of the nodule, always starting from the deep part of the lesion and coming back with very small and short shots of radiofrequency in order to cover at the end the entire mass, reaching possibly the borders of the lesion and saving the area, the central area close to the trachea, where the laryngeal recurrent nerve, the trachea and the esophagus are located. For the procedure, we used this new very good radiofrequency machine, Cambridge Interventional. The machine uses internally cooled electrodes, 18 gauge in size for the thyroid ablation. And we selected for this specific case a 1.0 centimeter active tip in order to be able to move quite freely inside the large nodular mass. One of the advantages of this system is that it shows in real time all the data regarding the procedure. I mean, the data regarding the power, the size of the lesion, the joule given to the tissue, and the watts given to the tissue. So all the data are given in real time during the procedure. As I said, with the moving shot technique, multiple small ablation units are ablated unit by unit, moving the electrode. The electrode tip is initially positioned in the deepest and the most remote portion of the nodule, after which it is moved back to the superficial and nearest portion of the nodule. This is the excellent view of this electrode. The quality of visualization of the electrode used here, 18G, is extremely good in every phase of the procedure. This allows to control precisely the location of the needle and also the progressive formation of gas seen here in the lower image here, which should reach for every procedure, possibly the capsule, the peripheral capsule of the nodule. This is the real-time procedure described for this case. The initial scroll of the lesion in longitudinal and in axial scan, our attempt to try to get out of the lesion all the fluid before ablating, but as you can see in a moment, the fluid tends to reform immediately. At that point, we decided to stop the procedure of aspiration of fluid and perform directly the treatment. As you can see here, a few seconds after the aspiration, most of the fluid reformed completely, occupying most of the nodule. The nodule has a solid and a liquid portion. This is the start of the procedure with the introduction of the needle. And the start, we start from one of the poles, either the upper or the lower pole of the nodule, and then move towards the other pole progressively, area by area, in order to ablate the entire nodule. At the end, immediately at the end of the procedure, we re-inject sulfur hexafluoride, our ultrasound contrast agent, to visualize if there are still viable areas inside the lesion or the lesion is entirely covered. As you can see here, there is no residual viable tumor, solid tumor, consistent in the entire mass. So we considered the procedure finished at that point. It is important to notice that during the procedure with this ultrasound machine, when the impedance of the tissue starts increasing rapidly, we hear a whistle informing us that we need to withdraw the electrode and try to cover another portion of the nodule. This allows to cover adequately the entire mass without wasting time and without achieving too much necrosis in a small area, which could theoretically cause charring. And charring is the negative point for radiofrequency ablations. In this specific case, we delivered 40 watts for 9 minutes and a number of joules of 27.4 kilojoules. This is the pre-ablation image of the lesion, and this is the post-ablation, as I said, demonstrating the complete disappearance of all the solid portions of the lesion. We had the opportunity to have the first follow-up of this patient, a 3-month follow-up, visibly demonstrating a significant reduction in size with some residual vascularity in the middle. But when we injected contrast agent, sulfur hexafluoride, all the residual solid portions disappear completely. So the result was still good. And when we calculated the volume, the residual volume of this lesion at only 3 months after the treatment, it was surprisingly very small, 3.7 by 2.2 by 2.4, with a volume of 10.2 cc's. So the size decrease in only 3 months was from 77.5 cc's to 10.2 cc's. So the reduction in size was 87.8%, I repeat, in only 3 months. This is really an enthusiastic result, demonstrating the validity of the thermal ablation of thyroid benign nodules and the excellent activity of this new machine, which allows it to reach in a short time precisely all the areas, always visualizing very well the position of the electrode during the procedure. And just at 3 months, visibly, the neck of the patient decreased markedly in size. You see here on the left side is the pre-treatment. On the right side, there is the 3-month appearance of the nodule, almost completely disappearing on the clinical observation.